My name's Harvey, and I'm going to be running today's seminar for you. It's going to be on tissue viability, and we've got Jacqui Fletcher, who is going to be going through lots of valuable content on that today. She's a nurse, very experienced nurse, and an expert in wounds and tissue viability. So she's going to take you through the content today. A few housekeeping points before we hand over. Please can everyone make sure they're muted so everyone can hear properly. And there's going to be a couple of opportunities for questions to be answered during the session. So if you can put your questions in the chat box, we'll get as many of those answered as we can. Other than that, we're going to keep to about 40 minutes, and we will hand over to Jacqui to learn more about tissue viability. Thanks, Jacqui.
Good morning, everybody. Just remember to make sure I wasn't muted, which is always a good start. Thank you, Harvey, for introducing me, and thank you, Felgains, for asking me to present this session to you today. As Harvey said, I'm a nurse. My background is very firmly in nursing. I've been a tissue viability nurse covering both acute and community. I worked for quite a long time at University of Hertfordshire, delivering both a bachelor's and a master's programme in tissue viability. I have been the clinical lead for the Welsh Wound Innovation Centre, and more recently I'm working with NHS England and NHS Improvement on the Stop the Pressure programme. I also am the clinical editor for the Wounds UK journal, so I spend a lot of time working with them and doing things like the Harrogate's conference programme. So we're going to talk about tissue viability today, and I guess for a lot of you this is something that you hear talked about a lot, and depending on your background you may have covered tissue viability within your training or not. But certainly one of the things that I guess for everybody is really important is that we've just come through, or hopefully are coming through, what's been quite an interesting and challenging time, and that I think certainly for us in tissue viability we have found it very, very challenging, and there have been a lot of lessons learned from our period of the acute phase of COVID. I think amongst them, that what I have seen from my colleagues is I'm astonished by the amount of innovation and creativity and how people have managed with very few resources, very difficult scenarios, and they've managed to do things. It's been very clear that there's been a lot of blurring of boundaries. So tissue viability has very traditionally been seen as a nursing role. It's something that nurses do. But actually, we've been very surprised at how much boundaries have been blurred, whether that's professional boundaries, working with our therapist colleagues, or whether that's geographical boundaries, people stepping from acute into community or the other way around, or working in nursing homes. I went from my very admin desk-bound job and spent 14 weeks working in my local acute hospital as part of the COVID transfer team, which was fabulous. I got to see things working primarily in ED and the assessment wards that I know I've talked about but haven't seen for a good number of years. So it's been interesting, and I'm trying to see it in a positive way as a learning curve. But certainly I think one of the biggest things for me was seeing non-nursing colleagues being engaged and involved in pressure area care in particular, but also other elements of tissue viability. And I will refer to that throughout this session. I guess for a lot of you, what we saw was a reduction in the contacts with patients. We were trying very hard to reduce the number of people who were seeing patients, whether that be in hospital, in care homes, in their own home. So what we were looking at is whoever went in, what skills did they have that we could do? So rather than concentrating on an individual task, so a nurse going in to do something, a physio or an occupational therapist to do something else, how did we share those roles? And certainly one of the things that we saw a lot was our podiatry colleagues stepping up, and instead of concentrating on below the ankle, doing a lot of work up to the knee. And we know we've trained an awful lot of podiatrists to get involved in things like compression bandaging for venous leg ulcers, so that they are now really enjoying that skill, and we're seeing much more motivated teams doing a lot of work around those areas of care. But I think common to us all, whatever your profession is, whether you're a registered professional or an unregistered professional, we have certain common core skills. And fundamental to that is assessment. Whatever your discipline, we are taught that the cornerstone of what we do is a good patient assessment. And that encompasses physical assessment, but it also encompasses the psychological and the social aspects of assessment. And in my field of care, those two, I would say, are as equally important as the physical, because you've all dealt with the patient where you've worked out what the problem is, you've put the best resources in, you're doing all the right things. But if the patient doesn't want that piece of equipment, the patient doesn't like that piece of equipment, then they're never going to use it. So when we talk about assessment, although I may focus very much on more clinical aspects, on physical aspects, I would always refer back to the social, the psychological, the environmental aspects of those as well, as being crucial to engaging patients in what we do and ensuring that our outcomes and our objectives are met. So in terms of tissue viability, I'm guessing you're all vaguely interested in it, or else you wouldn't be on the conference. But just to kind of say a little bit about what we do, because I think not everybody appreciates that the breadth of what a tissue viability nurse does get involved in. We see patients cradle to grave. So my worst patients are premature babies. I'm a real softie, I'm a grandma, and having to go into paediatric intensive care reduces me to a heap. So I have to cry before I go in and then gird my loins for what we're going to do. But it's very challenging because their skin is very different. We are increasingly in my field seeing patients who are over 100. Our average patient age is 75 upwards. But we also see a lot of people between those two. There's this perception that leg ulcers, pressure ulcers are a disease of the elderly. Actually, they're not. They are increasingly a disease of the 35, 40-year-old patient. And certainly when we're dealing with patients with diabetes, that's often a younger patient group. But as well as our three most common wounds, the pressure ulcers, lower limb wounds, leg ulcers and diabetic foot ulcers, we see many patients with complex surgical wounds. And by complex, I don't mean large. We can see patients who've got a surgical wound that they've had for 4 or 5 years, and all they've got is a centimetre bit that hasn't healed up. We can equally see patients who've got their whole abdomen wide open and bits of bowel spilling out, or patients who've had major amputations. We see a range of unusual conditions, so things like Stevens-Johnson syndrome, epidermolysis bullosa, bullous pemphigoid, lots of blistering diseases that you may come across. And certainly in the recent situation, we've been involved with the COVID skin manifestations. That was one of the most played down elements of COVID that from my perspective, people didn't know about. So we're starting to hear a little bit about COVID toe. I don't know if any of you've seen pictures of COVID toe. Very much looks like chilblains. But there are some really good papers. So there's a paper by a Spanish team, Casa et al., that has almost like a photo library of skin manifestations in COVID, and particularly in patients who had lesser symptoms, less obvious symptoms, you often saw a rash that went alongside this. So it's been really interesting. We look at general skin health, and for me, during this most recent period, that skin health has been for staff as well as patients. So we produce some guidance on skincare under PPE, and we're just working with the team ready for the second peak or second wave on hand care. So there's really good resources from the Royal College of Nursing about hand hygiene, but they do very much focus on the infection prevention side of that. And what we've seen are lots of staff and also patients and families with quite sore hands because they're washing their hands much more, they're wearing gloves much more, they're using a lot more alcohol gel, and they're missing out on really sensible things like making sure the hands are dry, or washing the hands and applying gel while the hands are still wet and the gel's been inappropriately absorbed. We also, particularly in our end of life care patients, see some very complex wounds around fungating wounds, and they can be challenging much more from a psychological perspective as well as the actual practicalities, because you're dealing with, that's an embodiment of the fact that the patient may be imminently dying, and they're often very smelly, they can bleed, they leak a lot, and they're often in very difficult to manage places. So that's an overview of what we do in tissue viability. I want to focus now on how we can all be engaged and involved in that, and how, irrespective of who you are and what you are, so whether you are a patient, whether you're a family member, whether you are a support worker, whether you're a therapist or a nurse, what are the two really important things that you can do on every patient contact? And for me, those two things are around skin assessment and a review of mobility and activity. And if you only do those two things, then you will have done a really good job. I'm hoping a lot of you are familiar with the Siskin Framework. So in pressure ulcer prevention, we talk about Siskin. We've recently elongated that to asking, the A being for assessment and the G for giving of information. But if you don't know Siskin, the first S is for the patient's skin, check the patient's skin. The second S is for the surface that the patient is cared for on, and that's wherever they are, in the bed, in the chair, or whatever it may be. The K is keeping people moving. The I we tend to think about of incontinence, but it's also for increased moisture. So particularly in this most recent period, we've seen some very sweaty patients who've had really high temperatures, and what we've seen is a lot of moisture damage. And the N is for the nutrition and hydration. Again, a lot of work around nutrition, less on hydration. We need to make sure patients are drinking very well. So mobility and activity, two slightly different things. People can be immobile but active, so they may be paralysed from the waist down, so not able to walk, but they can be quite active. And we also need to think about these two things in terms of prevention of harm. So I'm sure you're all very familiar with the fact that a pressure ulcer is classed as a harm, a patient harm, and it is therefore an incident and recordable. But we also see that there are common things across the reportable harms, which are pressure ulcers, falls, VTE, clots in the leg, and catheter-associated UTI. And all of those, but the assessment and the management really focus around mobility, nutrition, hydration, and use of equipment. And what we should be doing is thinking about these in cross-cutting themes rather than seeing them in silos. I'm doing this to prevent pressure ulcers. I'm doing this to prevent a clot. I'm doing this to prevent a fall. Actually, if you take the taskness away, what we're doing is delivering fundamental elements of patient care. And we need to make sure that we're not doing conflicting things. So I'm sure you're all familiar with what we sometimes call the red socks, the prevention of fall socks. As tissue viability nurses, we hate those socks in the same way that we hate the anti-embolic socks. Because once you put them on, the heels don't get checked. Once you put them on, you make the feet and the heel very much more at risk. And you know, when we do pressure ulcer audits, we take every single pair of anti-embolic socks off. And I can tell you those socks have not been taken off every day. I know that by the snowstorm that comes when I pull them down from the dry skin associated with those patients. And a really important element of skincare is moisturization. Make sure it's clean, dry, and well moisturized. That's, you know, the third element of skincare. So when we are using equipment, we have to remember to forget about the silos and make sure we're not conflicting with our own objectives. So a fundamental skin assessment is really important. It's not a difficult thing to do. We all have eyes, we all have hands, we can check the skin, we can touch the skin, and it flags things really early for us. It's important to understand that some of the things we see in textbooks are not always what we see. So in pressure ulcer prevention, we talk about non-blanching erythema. If the patient has a red area and you press it, in healthy skin, that will go white. If any of you press on your skin, you will see it changes colour. If it doesn't change colour, then that's the first sign of a pressure ulcer. That's a category 1 pressure ulcer. But we are increasingly aware that in non-white skin, we don't get that redness. We have erythema. Erythema is a physiological process. It's an inflammatory process. It's a rush of blood to the skin. It's an increase in blood in the area, but it depends on the colour and the tone of the skin about what you will see. So we also need to think about using our hands and using our other senses, feeling the skin. So you're feeling for temperature change, not just what the temperature is. If somebody's been sat on their bottom, it will be warm, but feel, is there an area of intense heat? And if there's heat, that's generally inflammation, so that may be reversible. If the area is cold, then you've possibly lost the blood supply and that skin is much more damaged. Think about skin changes not just in terms of pressure ulcers. When we're looking after patients with lower limb disease, in a venous leg ulcer, you'll often see that dark brown staining of the skin. Patients with diabetic foot ulcers, we're looking for presence of callus. Callus tells us there's abnormal loading. It's a protective mechanism. And I'm sure you've all come across patients who don't like podiatrists because they've been to the podiatrist with just some hard skin and they've come back with an ulcer. Actually, the ulcer was there under the callus in the first place because that callus was there as protective. Also think about edema in skin, because we have so many patients now with lower limb edema, and that reduces the mobility. If the leg is swollen and heavy, it's going to impact on their overall mobility, but also on their ankle mobility. And ankle mobility is really important in calf muscle movement, which is important in returning blood flow, venous return, which in turn impacts on edema. So some really key things about skin and looking after skin. Mobility itself is important in terms of prevention of harm. So if a patient is mobile and self-mobile, then they are far less likely to develop pressure ulcers or to develop VTE or even to develop catheter-associated disease, because if they can reposition, they're moving the body around, you don't get stasis within the bladder. But we also need to think about what the equipment we use does to those other things. So we are very good at putting patients in beds, putting them on specialist mattress, putting cot sides on, and actually that increases their risk of pressure ulcers for some patients because it reduces their mobility. So if you put them on a specialist mattress that makes the bed higher and they can't get into it from a wheelchair, or they can't get into it or out of it because they've had a stroke and the edge isn't stable, then you are reducing their self-mobility. So we need to think carefully about that. And if you're selecting a mattress for any patient who has proprioception problems, whether that's a stroke or a neuropathy from diabetes, think very carefully about what the edge of the mattress feels like. If they have a firm edge so they feel stable, you're more likely to get them to be more mobile. We also need to think about the role of shear. We're increasingly talking about shear in pressure ulcer prevention. And shear is a very difficult thing to describe. It's about the internal thing. So I guess you're all familiar with the scenario. If you're on a long drive, when you start off, you can see in your mirror in the car, but by the end of the drive, you have to tilt your mirror down. Your bottom's not moved, but kind of your skeleton's moved within your skin. And you can test this for yourself. You can sit up in your chair, put your hands under your bottom. If anybody wants to do it now, give you a minute because we've been talking for a while. You should be able to feel the points of your pelvis. Can you feel that there underneath you? And don't move your bottom, just kind of relax down. You can feel that your hands are no longer under the bone. So what that tells you, take your hands out before they go numb, is that the bones move forward and all the tissues between the skin and the bones being pulled along and it's been twisted and torn. And that causes a lot of damage. So when we are putting people on equipment, we need to think about what that does in terms of the moving in the bed. And I guess a lot of you spend a lot of time lifting patients up and down beds where they've slipped down. And that causes both static and dynamic friction. Static friction being that before they slide, you've got a huge amount of shear. You've got all that movement internally with a high shear. Once you get dynamic friction, once the patient moves, the shear is less, but the surface friction is quite high. And that we know causes as much damage as pressure does. In terms of mobility, a lot of our pressure ulcer risk assessment tools ask about patient's mobility. Can the patient mobilise? And I just want to refer you back to my comments at the beginning about psychology and environment and the impact they have on mobility. I see lots of patients who can mobilise, but they don't. And they don't mobilise for many reasons. That can be we've sedated them. It can be that they're depressed or that they feel unsafe in their environment. So when I go into a patient's home, a patient will tell me they are mobile, and I will watch them go into the kitchen. And what they do is they hold on to the back of the sofa, and when they get from the sofa, they grab onto a table, and then they get to the kitchen door and they hold the handle, and in the kitchen, they walk along the surface. The minute you put that patient in a hospital, in a bed, with nothing else around it for the patient to hold, they won't go to the toilet because they're scared of falling. Their mobility hasn't reduced, but psychologically they are afraid. So we need to remember that mobility is about can do and does do as well. It doesn't matter how much they can. If they don't do it, they are not mobile. When we're talking about moving patients and the manual handling of patients, there are lots of things we need to consider. There's a whole range of equipment, and I'm sure Felgains will tell you about the equipment they've got after this. But again, we need to think about doing this as a functional thing, not just a task orientated. So in tissue viability, in our K for keeping people moving, we talk a lot about repositioning schedules or interventional rounding. We reposition patients 2 hourly, 4 hourly, whatever it may be. What we tend not to do is to think about the actual movements that patient do anyway. So I get lots of people tell me, we've repositioned the patient, we've put them in 30-degree tilt, and the patient kicks their pillow out. If the patient is able to kick their pillow out, do they need pressure relief for that leg? Because actually their leg is quite mobile. If the patient's seeing a therapist and you go and you realise the patient was due to be turned at 1 and it's now 1:30 and the patient hasn't been repositioned, but actually the therapist's been and they've practiced stairs with them, do they need to be repositioned at 1:30 because they've just practiced walking the stairs? We had one of the hospitals I did some work with around quality improvement who had almost a head-banging thing with their therapists about, particularly post-lunch. All the therapists went for lunch at lunchtime at the same time. The nurses would feed the patients, they'd get them back into bed for a rest because the patients were tired, then the therapist would come and get them out. And that was really frustrating. You know, you're repositioning the patient back into bed and then suddenly the therapist is stopping you. When they had a conversation about it, the therapist went for lunch to avoid the patient's lunchtime. What they didn't realise is that patients were then tired and were going back to bed for a rest. And actually the therapist could come and assess mobility as much in helping the nursing team get the patients into and out of bed before lunch and after lunch if the nurses had just told them. And that kind of communication is really important, because repositioning isn't just about it's your 2 hours is up. It's about what does that patient need to do in terms of their activities of daily living. Can we build things into normality rather than just seeing it as a task? We are increasingly seeing use of both mechanical and automated turning systems, and I think the guys are going to show you some afterwards. These are really, really helpful. And mechanical and automated turners have a great place, one where you have fewer people around, and two, where for the patient being manually handled can be a problem. And that can be a patient who's in a lot of pain. So to physically reposition a patient, even if you're using slide sheets, even if you're being as gentle as you can, that can cause them pain and distress. It also can be challenging for patients who are confused, patients who've got dementia, patients who are slightly sedated, and where they can become very agitated and can become quite violent if you disturb them. And I guess you've all met that patient where you've spent the last 2 hours trying to settle a patient, and you look at your watch and you think, oh, it's repositioning time, and you've only just quietened them down. But again, practically, if they've been agitated and all over the bed, do you need to do that reposition? So the mechanical turners can help you with that slight distance from the patient so that they don't feel as intimidated. You might not agitate them as much. They are not automated turners. They don't do it on their own. One of the problems with the automated turners, so some of you may be familiar with the systems that auto-inflate and turn patients, and you can set the timer to do that. For me as a tissue viability nurse, it always gives me a slight heart sink moment, because when you physically go to a patient, you do that second important thing. You do a skin assessment. So you check if the patient is wet. You look at the skin to see if it's red. And if you're not physically going, you're not physically doing that assessment. So whilst they have a place, particularly in the home care setting where the patient might only have 4 times a day carer, you know, there's nobody with them the rest of that time, I think we need to be really cognizant of clinical interaction is actually really important. Going to that patient, checking their skin, making sure they've had a drink, making sure the skin is clean and dry is useful. We also need to think about what we're doing in terms of offloading. So we talk in tissue viability a lot about 30-degree tilt. We reposition a patient in bed and chair, not on large bones. So as a student nurse, I was taught you position a patient side to side and on their back, which would put them on either hip or on the coccyx. We now do 30-degree tilt, which puts them on the buttock, a big muscle, much better for preventing pressure damage. But when we do this, we need to think about how we do it. So we traditionally use pillows. How many of you've got enough pillows? How many of you've got good quality pillows that when you put them between the patient's knee, the content doesn't all shoot to either side and you've just got pillowcase between the knees? When we are supporting the patient's leg, we sometimes use things like wedges. You need to think about how you offload the heel without causing damage at the knee. If you lift the foot so the heel's up, what you are doing is putting the knee into hyperextension, and you can cause damage to the ligaments and tendons of the knee. So make sure that you've got a slight bend at the knee. When we position the patient, we very carefully in tissue viability talk about don't elevate the head of the bed more than 30 degrees. If you start sitting the backrest up, that increases the shear at the buttocks. The patient's far more likely to slide. If you're dealing with a patient with a chest condition or a respiratory condition, if you've got a patient in intensive care, they say the minimum elevation is 30 degrees. So you have to think about the conflict there, about what it is that you want and what's best for the patient. Don't forget about repositioning in the chair, much harder. And some of the really specialist equipment companies we see now are developing chairs that allow you to tilt in space. Again, when I was a student nurse, we used to use recliner chairs where you'd pull the back, stick a table on the front, and the patient couldn't move unless they slid down and got their chin stuck on the table. Now what we're doing is using what's the equivalent to Trendelenburging in a bed, using a tilt of the whole thing to move the position. And don't forget about that in bed. If the patient doesn't like being sat up, if the patient constantly slides, you can tip the whole bed base, and that will help you redistribute, whether that's head to toe or side to side if your equipment allows it. And remember that supporting the patient in that position with pillows, with positioning devices, whether that's wedges or the larger pillows, is important, because the fundamental aspect of pressure ulcer prevention is the more you spread the weight, the less weight there is on any particular area. And if you think about a patient with a stroke, their very common position is this, isn't it? They lean to one side. So they put in all the pressure over one point of the pelvis. Just by supporting them to sit equally, you're distributing that weight equally across both ischial tuberosities. So good posture is really important. And I want to kind of finish by talking about something else that really came to the front during COVID, which is around patient self-care. Working in the community, I've spent a lot of time trying to get patients to care for themselves, to not become medicalised, to not rely on me to go and do their dressing. And it's felt a lot of times like I've been banging my head against a wall. But suddenly they didn't want to see us. They didn't want people going into their home. We didn't want people going into nursing homes. And what we've seen is a lot more people sort of wanting to deliver theirs or their family's care. And this has been fabulous. There's been a whole range of resources for supporting self or shared care, and that are on the National Wound Care Strategy webpage. They're all free to download if you want to go and see them. But if you are going to encourage patient self-care, there's just a few things to think about in terms of governance. If you're asking the patient to self-care, it's not about reducing your workload. It's about empowering the patient. It's about making sure that they're safe to do it and that they can do it, that they have the skills and the understanding of what they're trying to achieve. It's about thinking about what safeguarding have you got in place. So, for example, if you're telling a patient to apply their own compression hosiery, what do they do if they find a pressure ulcer under there? What do they do if it feels too tight or if their leg swells? So they must know that how to take it off, who to contact, what is a red flag. If they're doing their own dressing, what are the really easy signs and symptoms of infection that they know that they need to get help? If that wound's suddenly exuding more, if it smells more, if they run out of dressings, who do they contact? So whilst self-care and shared care is really good, it's important that we see it in a safe framework. So I'm conscious of the time, and I just kind of want to draw it all together to say, whilst those two assessments, skin assessment and mobility assessment, are really fundamental, and that everybody who sees a patient should have those things in mind in terms of prevention of harm, not just pressure ulcer prevention, prevention of falls, and lots of other things, about motivating patients, about engaging others, thinking about that safe environment. We also need to remember that communication is really important. Communication across teams, communication with families so that they understand what's happening, and that we appropriately document. I see lots of repositioning charts. I'll go into a bay in a hospital and I'll see that every single patient was turned at 12 and 2 and 4. There's only 2 staff on duty. How did they do that? It's important that we document the time that we did do the reposition, not the time that the chart said that you should, because then you can plan. We can't always get there on the dot, and we sometimes reposition earlier because the patient was uncomfortable, because the patient was eating, because the patient needed to do something. So if we then leave the next one, then that's too long. So we must document what we did, not what the plan said we should do. We must think about what repositioning does for patients, and that when we're repositioning, an important part of that is that skin inspection, whether that be the touch, is the skin wet, is the skin hot, or whether it's what you see visually. And you know, we see some really interesting things in tissue viability, and for those of you who are nurses, I know we're great ones for picking. We like to get a nice dry crusty leg and take that off. But think about what you're doing when you're doing that. What's underneath that? So I'm conscious that there has been a lot of information there. I think somebody asked right at the beginning, will there be slides available to share? I have done some slides. You might have noticed me glancing to the left of my computer. I'm happy if Harvey wants to share those, you can. They're not very detailed. It's just kept me on track to remember that I said everything. There are some links in there. We have got links to the Siskin poster, and I will put the link to the Stop the Pressure page, which has got lots of resources around Stop the Pressure, and also the Love Great Skin page. Love Great Skin is a piece of work we did when I worked at Midlands and East with Wounds UK, and it's a much more visual representation of Siskin. It's based on Siskin, but it's much more visual. So if you've got people whose reading age is not good, whose first language isn't English, it may be more appropriate for them. I'm happy to take any questions. I know for some of you the equipment may be new, so I don't know if the guys want to demonstrate to you. They've got Manulette, Vendulette and Legulette, so that's the the mechanical repositioner. They've got the cushioning devices and a whole host of other things. So if I hand back to Harvey, who can maybe show you how to use some of that, unless anybody else has any questions. Thank you.
That's absolutely brilliant, Jacqui. Thank you so much for that. Lots of great content in there. If there's any more questions, please put them on the chat, and we'll get as many of those answered as we can. If it's for the tissue viability side of things, it'll be Jacqui that answers those. If there's anything around any equipment, then by all means, I'll try and answer those. I'm conscious we've only got about 10 minutes left, so there's lots of equipment that we do that can help with repositioning, that can help with pressure relief and holding people in and supporting people in a stable pressure relieving position. So if anybody's got any questions around a specific case, there's not enough time to go through everything now. If anyone's got a case that they want to go through in more detail, then by all means give us a call, and we'll go through the specifics of your case and see if we've got any equipment that could potentially help. Let's have a quick look at moving into a 30-degree position using the Vendlet turning system here and the Liolet positioning cushions. So my colleague Grant is going to jump on the bed for us. So Jacqui mentioned about pillows, and it sounds like a lot of people are using pillows to do the repositioning, to try and hold people in that position and to offload bony prominences, etc. One of the situations that Jacqui mentioned was putting a pillow between the legs, and you've got all the material moving from side to side. There's a lot more detail on this, so I won't go into it too much. The Liolet positioning cushion, it's spelt with a J in the middle, which confuses a lot of people. It's pronounced Liolet, and this is one of the many cushions. It's viscoelastic foam coated in a breathable, vapor permeable coating. So what that can do is we can put that between the knees like that to offload the bony prominences there, particularly in a sideline position if needed. So the other piece of equipment that I'm going to do to support the 30-degree position is a wedge here, which is actually 27.5 degrees, and then what we call the pad high, which is going to support the leg when we're in that 30-degree position, and that's going to keep the spine nicely aligned so it's as comfortable as possible in that position. So to assist me with the repositioning, I'm going to use the vendlet. Doesn't have to be used with the vendlet. I need to make that clear. If you're using this on a normal profiling bed and you've got the staff to do the repositioning yourself, then it works just as well on a normal bed without the reposition, without the vendlet turning system. So just going to bring Grant closer to me, and then I can prepare the cushions for the turn. So I'm going to put that there, ready to take his top leg as it comes over. Then I'm going to raise this side rail. It's going to help us with the turn. Move this arm away from his body so it's going to be comfortable when he rolls over. This arm across his chest. Then I'm going to do the turn. So move that top leg onto the pad high. So we've got a nice stable position there. Then this wedge I'm going to tuck in behind him so that when he lies back on it, he's got that tilt. So I'm going to use the vendlet to move him away from me. I can tuck the wedge in behind. And allow him to sink back into that position. And then just make sure his leg is nicely supported on there, and there's no pressure on the heels. And there he is in a 30-degree side-lying position. So there's a couple of things that are going to help you with repositioning for pressure relief. Obviously, if you're doing it on a schedule, you can then repeat the process, put this wedge in around the other side, and support the other leg up on the pad high there. Any other bony prominences, if you're trying to support the scapula, you can put something underneath there, or for an elbow, put that there. There's so many different things we can do with these positioning cushions. Has anybody got any questions? I know we're running out of time. Any more questions for either Jacqui or myself?
I think, Jacqui, you mentioned about people who might be quite a little bit mobile in bed, and there's a need to maintain their mobility. So putting a bed rail might be quite restrictive. Is that something, for example, someone who's had a stroke but is regaining functioning tends to move their legs off almost over the bed rail? Would you suggest something, and the person is always on observation, would you suggest that we could have him, more mobile by, enabling him to move his leg on the bed freely rather than trapping it with a bed rail and bed bumpers?
Yeah, I think this is one of the challenges we have, isn't it? It's often very conflicting information. So I know exactly the kind of stroke patient you mean, where they're just starting to regain the function. They're not quite fully back with us, and they're very active in the bed. So I think the difference is between activity and mobility. So when the patients are moving their arms and legs, we describe that as activity, not mobile. And that's not necessarily the kind of patient where I was talking about where you're improving mobility. I was thinking a bit further along that, where that patient's starting to actually want to mobilise, you're wanting to get them out of bed. So of course you have to maintain safety and keep them in the bed. But with that kind of patient, I would also think about how often we were repositioning them and how effective that is. So there's nothing more frustrating than going along, it taking 3 of you to get the patient on their side, and you get them all really nice and comfy, and you turn around, you document it, you walk back to the bed, and they're exactly in the position that you put them in, they were in before you repositioned them. And if the patient is that active in the bed, you need to think about, what's the repositioning achieving? What else could you do? Are there different things you could do? Could you use the bed frame to sit them up more? Could you lie them down more? Could you think about, one of the most frustrating things for a patient with a stroke is lying them on the side they can use. So can you avoid doing that? Use their back and their less good side more. Could you use the tilt? Could you use the knee brake function to do lots of different positions. And we've seen, particularly during COVID, I don't know if you know, in COVID, we've been using a position called prone, where we put a patient face down and put them in swim, so one arm up, one arm down, and they're in that position for 16 hours. We can't turn them. So we've been looking at smaller movements. So what can you do that would be a smaller movement? So whether that's just moving a pillow behind their side to drop them down and putting it on the other side, that allows them that activity, because that activity is actually reducing the pressure, because it's moving their limbs around, it's probably moving their buttocks around, you know, get them doing their pressure relief.
Thanks for that. I think we're drawing to the close. As Jacqui said, there's lots of resources, including the Siskin and the other tools that were mentioned, the slides, the links to some of the products we've been talking about. We'll send that round in an email afterwards, along with the recording of this session, and we'll look forward to seeing you in future webinars. We've got one next week on care for paediatric patients, and lots of other interesting webinar topics coming up, so do keep an eye out for those. Thank you very much, Jacqui, and thank you very much everyone else who has made the time to come along this morning.